All right, welcome to another edition of the Surgeon's Record webinar. I'm your host, Ben Schwartz, and today I'm honored to have with me Dr. Mary O'Connor, currently serving as Chief Medical Officer and co-founder of Vori Health, but has spent 24 years at the Mayo Clinic and recently was running an innovative Center for Musculoskeletal Care at Yale before joining Vori and founding Vori. So, Mary, I would just like to start off by having you tell us about yourself, tell us about your journey, from being an orthopedic surgeon to co-founding Vori Health and becoming the chief medical officer.
Well, Ben, I'm delighted to be with you. I've been looking forward to this. I know it's going to be a lot of fun. And, I guess my journey has always been kind of grounded in how can we make care better for patients. And when I was chair of orthopedics at Mayo Clinic in Florida, I introduced a non-surgeon physician into our all-surgeon department, and then a second, and that model worked beautifully for us. And we were able to get the surgeons into the OR one more day every other week. So basically, I could increase surgeon capacity by 20% without hiring more surgeons, and the patients loved it, and we had a lot of concern in the beginning from leadership. Well, Mary, the patients are coming to your department to see surgeons, and they're not going to see surgeons, and they're going to be all upset and disappointed. And of course, we take patient complaints and concerns very seriously. So we surveyed, monitored, and it just didn't turn out that way. We committed that if one of the non-surgeon docs saw a patient who needed to see one of us, that one of us would see them same day, next day. And we were able to increase our contribution margin from my department by 19%. So that was like the...
I'm sure that resolved all the questions fairly quickly about the model working or not working.
Well, it certainly helped support it, right? Because we had solid clinical outcomes, we had improved financial performance, and we had patients having great experiences. In fact, it got to the point where, the internists who would, refer for ortho consult would then specifically request one of the non-surgeon docs.
And these were primary care trained MSK docs, or what was the background of the non-surgeon docs?
So those two physicians were family practice sports medicine fellowship trained. And when they would send a patient to me, Ben, it was just such a thing of beauty. This patient was totally teed up and ready for me to have a conversation that focused on the surgery. Okay, you have end-stage knee, OA, osteoarthritis. You've had all the non-surgical care. You're ready for knee replacement surgery. Now, I can go in and talk about what your expectations are for the surgery. Really focus on what do I think the surgery is going to give you? Let's make sure we're aligned with realistic expectations. Let's talk about the risks. It was just such a wonderful, wonderful model and a great experience. So that's when I knew, we're doing MSK care, not in the team-based approach that we should be. The surgeons are critically important elements of a team-based MS care model. But I don't think the surgeon should actually be kind of the lead driver.
Right. Yeah, and I agree with you there on that model. I think it's the highest yield thing for the patient, for the doctor. I think depending on sort of the practice model that you're in, some orthopedic surgeons would love that and embrace that. Some would say, well, I need to see that non-surgical patient. I can't operate on everybody that comes through my door as much as I might like to. So in a private practice model, there might be some pushback on that. And is that why maybe we haven't seen this model catch on? Because I think it would be great to have non-operative sports medicine trained. Maybe they also are comfortable managing the patient's medical problems, not just their MSK problems non-surgically. Why do you think that model hasn't become more prevalent, or is it catching on in other places?
I think there's a natural resistance by surgeon groups to adopt this model in a more holistic way, right? So, it's like having non-surgeon docs in a practice is nothing new to big private practice groups in orthopedics. They've been doing this for a long time. But they don't do it in a systematic way, right? That like everybody doesn't come in and first see the non-surgeon doc and get that level of non-surgical care, as I'm saying as a general rule,
Sure.
right? And that's really where I think a lot of the opportunity is. So why are the surgeons resistant? Well, I think that we still think as orthopedic surgeons that we are the best doctors to drive musculoskeletal care. And I respectfully challenge that because I don't think that we are well trained in non-surgical care anymore. And that's okay. You know why that's okay? Because surgical care has become more and more complicated, requiring a higher level of expertise. So it makes sense that the surgeon should focus their skill and training on the surgical aspect and let initial non-surgical care go to another physician type. So, but I think there's an element of fear in that for orthopedic surgeons that they're going to lose control of the patient. There's going to be negative financial repercussions because, you still generate revenue from non-surgical care in the office. I think there are ways around that, creative ways around that, and we'll see if we can get people to embrace those.
Yeah, I think things are seen to be headed in that direction one way or the other. CMS is rolling out these programs, and if you sort of look at the trend as we move from BPCI and CJR into team and into making care primary, there seems to be this focus on, maybe shifting more of the specialty care into the primary care setting, or incentivizing more of the non-surgical care, even for surgeons. And I think it's still remains to be seen what exactly that looks like. How do you see that model working out? Should primary care doctors be doing it? Should surgeons be doing it? Is there somebody that exists in the middle to be a liaison between primary care and surgeons? What's the best model to make sure the patient gets appropriate care, but also high value care?
Right. So that's really the model that we've built at Vori Health. And one kind of way I'll explain it to some people is to think of us as the bridge between the primary care physician that doesn't have extensive training in musculoskeletal and the surgeons who have extensive training in surgical treatment, right? But then there's this gap, and the gap is effective non-surgical care. And so when the patient goes from the primary care doc to the surgeon, we know that there's inappropriate rates of advanced imaging, there's inappropriate rates of surgery. And do I think my surgeon colleagues are bad or evil people? Of course not. But there's a human bias, right? When I've got a hammer, all the world's a nail. And again, I go back to, I just don't think we're adequately trained in good non-surgical care. So on the flip side, the non-surgeon MSK doc will be biased towards non-surgical care. We all carry our training biases with us. So I think that we need that bridge between primary care doc and the surgeon expert.
Yeah, and the other issue that always comes up around that, going back to the finances of it, because it always seems to sort of revolve back to that in these models. What does that look like? Is it, sharing risk, or the PCP and the specialist sort of in the same risk pool, or how do you solve that issue around who's being incentivized to do the appropriate care? Because as you said, the one argument is if you're incentivized to do non-surgical care, you're more likely to offer non-surgical care. Maybe that's appropriate, maybe it isn't. Flip side of that is if you're incentivized to do surgery, that's going to be your bias to do surgery, whether it's appropriate or not. How do you bridge that gap between what the incentives are? Because it seems if you incentivize one thing, you're going to kind of go in that direction, and it may not necessarily be appropriate in every case.
Right. So that is like the multiple trillion-dollar question, right? Because that would solve the healthcare, a lot of challenges that we have in healthcare now. I'll start more simplistically because I would say this, as we know, is a really complex problem. So do I think that we need to move away from the fee-for-service model? Yes. Okay, so how do we then advance the concept of a value-based care model in which we're also promoting quality and access and health equity. And what the models to date have failed to do is risk adjust for patient factors. Now, I know that can be complicated, but without it, we run the risk of cherry picking of healthier patients and lemon dropping of sicker patients. And we've seen this play out in value-based payment models for joint replacements. Now, there's been one study that I read that didn't show an access difference, but a lot of other studies showed a change in the pattern of the patients selected by the surgeon after these value-based payment models went into effect. And again, if I'm going to be penalized because I take on the sicker patient, the patient that's going to need to stay in the hospital, right? The patient that's going to cost the bundle more, I'm going to have a bad report card that somebody is going to put up in front of me and two other colleagues perhaps, right? And surgeons, no surgeon that I know wants to get a bad grade, right? That's not in our DNA. That's not how we work. No surgeon wants to do a bad operation, right? So nobody wants to be perceived as that failure or less than, not as good as everybody else. So this is why we see, surgeons now telling patients much more so than ever before, I can't operate on you because you are too obese. Like earlier in my training and experience, this just wasn't very commonplace. And now we see basically people, giving a hard stop, a cutoff that says, you need to go lose weight before we can do your joint replacement. Is that the right thing to do? This is again a very complex, controversial topic, but the fact that we don't risk adjust, I think, is a factor that dissuades surgeons from offering surgery to higher risk patients, and that then promotes more health disparities, which remains a major injustice in our system and a major problem in our society.
Yeah, for sure. I totally agree. There may be some self-selection bias because some of these programs are voluntary. They're not mandatory. So BPCI is voluntary. And if you don't want to accept that risk and you say, look, I don't want to, take that downside risk. I just won't enter the program at all. And you almost have sort of, cherry picked and lemon dropped before you even got into the program. We were in BPCI-A for several years. We dropped out this year, and we would have periodic meetings with CMS. Their argument was always, well, at the end of the day, it kind of balances out because for every high-risk patient you have a standard risk patient. But we know that's not necessarily true, that it's going to probably skew more towards the sicker patient, just based on that sort of population. So I didn't think that was a satisfactory answer. And I agree that we need better risk stratification mechanisms. If they can do it for Medicare Advantage, they can do it for us if we're entering into these programs.
And conceptually, I think that we really need to view it differently. I think that we need to have a philosophy and an approach that wellness belongs in the community and sick care in the doctor's office. And what we see is with these bundled value-based payment programs, it's like all the risk is going on the clinician or the surgeon or the system, whoever's accepting the payment. And now I'm supposed to be responsible for the fact that my patient doesn't have a family structure, right, that's going to allow them to recover at home, and they're going to need to be discharged to a skilled nursing facility. Like, why is that? Like, I can't influence that, right? I can't influence if my patient doesn't have access to fresh fruit and vegetables at a reasonable price. I can't influence if it's safe for them to walk in their neighborhood at night to get exercise. But yet, the health outcomes of those things are what we see when those patients come into the office. And somehow now we're responsible for accepting the risk of the medical care, which is influenced by all these factors, right? And
Yeah, for
that's
sure.
a fundamental problem.
Yeah, the social drivers of health are a huge factor in joint replacement surgeries. I mean, those were some of my biggest losses in the bundle, where, of course, post-acute care is the most expensive part of the episode of care. But who am I to tell a patient that has no other help at home, that here in Massachusetts lives in a house that has very narrow, tall, wide stairs and doesn't feel comfortable going home by themselves? I can't tell that person they have to go home because they're going to, be a bundle buster and I'm going to lose money on them. You try to do what's right for the patient, but there is not a good mechanism to account for that, in these bundle payments. And we know those factors have a huge influence on how patients do, their outcomes, and how much, they cost per episode. But we're not sophisticated enough to account for those things.
Right, and so therein lies a big part of the problem in terms of, looking at the bundled payments. And again, I really think that there are a lot of smart people in healthcare economics and people that have experience with, large data sets now. And I think that we should be able to move to something that looks like better risk adjustment for patients. And that doesn't mean pay the surgeon less for the healthier patient, right?
Right. Yeah, it can't be a zero-sum game. It's not fair to make it a zero-sum game. And it's interesting with all this talk of technology and AI, can we get more sophisticated? Can we get more personalized? I saw a paper that sort of looked at an AI model for total knee replacement and really tried to individualize the risk and what, for instance, the target payment should be for that specific patient given their risk factors. And if we can really get that granular instead of hey, this is the target price for every single patient that enters the bundle, then maybe we can get something that is personalized and sophisticated, not just from the clinical treatment that we give, but also what the expectations are on how that patient should do.
Exactly. And
so maybe we'll get there. I think that's sort of the hope with all this AI and data gathering as we go forward. So, there seems to be this negative pendulum swing against value-based care. It's kind of become this, four-letter word almost, because there's been so much talk, and it never seems to sort of match the talk. But is it wrong for us as orthopedic surgeons to dismiss it? Should we roll our eyes at it? Should we say it's never coming? Or do we risk sort of having things happen to us and kind of missing out on this opportunity? Are we naive to think it's just never going to come, it's never going to happen to us, or we can, because it's going to be voluntary, we can avoid it forever?
I think we would be naive to think that it's already here, and we would be naive to think that it's not going to come further and progress further. Healthcare costs remain out of control. It's a huge economic issue for employers, small businesses, etc. So controlling healthcare costs matters to the health of the nation, right? So this isn't going to go away. And fee-for-service has not been a model that we know is successful at trying to control costs. So that doesn't work. We already know that. So now we have to work on, can some type of value-based care model work where we're fair to the surgeons, the docs, the clinicians, and we're promoting good access for patients? So these are tough questions, right? But to respond to your initial question, I think that orthopedic surgeons would be putting their head in the sand if they think that this isn't coming, because it is coming.
Yeah, for sure. Especially if you're a spine surgeon or a joint replacement surgeon, because those are the big ticket items. I think you need to be aware of this. It is coming, and you don't want to be reactionary. You want to be proactive. How is Vori Health approaching this? Where does Vori fit into this picture? Commons Clinic comes at it as we're going to partner with orthopedic surgeons, and we're going to help them set up these programs and be efficient and work with payers. What's the Vori approach on facilitating these types of models or making value-based care work for MSK?
Well, we like value-based contracts. That's how Ryan Grant, who's my co-founder and the CEO, he's a spine neurosurgeon. one of the good neurosurgeons, like the old ortho neurosurgery kind of joke. So we will have contracts that are value-based based on some type of bundle payment arrangement. We're going to take care of your member for 12 months. And over this period of time, there'll be some milestone payments based on the number of clinical visits. Because, for example, if we see a patient and we say, this person is actually not appropriate for virtual care, then we wouldn't expect the payer to pay us the entire bundle. Right? That's not being a good partner. Per engaged member per month, other types of value-based payment arrangements are other types of contracts that we'll do. So we don't like fee-for-service. It doesn't really fit in our model of more holistic care, where we have, in addition to non-surgeon physicians and physical therapists, we have health coaches and registered dietitians for nutritional support. And so to pull those other clinicians into the care model for the patient, in the traditional system, a health coach isn't going to get paid for. A registered dietitian you can't see unless you have diabetes and kidney problems already, which is kind of insane, right? So we know that to support that more holistic model of patient care, we need this type of a value-based payment model.
Yeah, I would say that's one of the lessons I think we've learned as orthopedic surgeons. If there's anything that's come out of some of these value-based care models that we've had, is that we have to look at the patients more holistically. When I trained, it was, do a good surgery, make the x-ray look great, put that tip and knee replacement in well, and that's really your responsibility. And if you have an infection or dislocation or whatever, that's on you. But, we didn't really make the link between getting patients healthy before surgery or maybe picking patients that could do fine without surgery. And I think that's what these value-based programs have forced us to do for the better. Whatever you think about their finances, they have forced us to think more holistically about the patient, understand that, our surgeries don't exist in a vacuum. It's really about, making sure, setting the patient up for success. And hopefully that will continue and we'll figure out the financial piece of it. Where do you see, look in the crystal ball, 5 years from now, 10 years from now, where are we? Are we still, debating value-based care? Are we still trying to make it happen? Is there still backlash? Are we going to be able to make it successful? Are we going to be able to overcome these challenges of, incentivizing proper risk adjustment, proper way to address social drivers of health? How do we get there? Where will we be in 5 to 10 years?
I don't think it would be lovely if we would have it all solved, but that's not realistic. But I think that we'll be further along with broader experience in value-based payment models that are successful. And with every experience we can learn what's working well and what isn't working well. That's the challenge for us. And, I know you believe this and I believe this, is that physicians need to be at the table in leadership positions shaping those decisions. That is so critical to us solving the healthcare challenges that we face. So, yeah.
Yeah, I agree, 100%. It's not easy all the time, and I think we tend to be heads down and just kind of focus on what's in front of us, but I think we're in an era where that just isn't going to be sufficient anymore. If we want to have input and design a system that makes sense for us and our patients, we have to get involved, as painful as it may be and as frustrating as it may be. We just have to keep chipping away. Any parting thoughts, things you want to share we haven't discussed at this point? It's been a really great conversation. I think you and I could go on about this forever and ever and ever, but being respectful of our time limit, any parting thoughts?
I think that we, as a collective, need to continue to say the patients must come first. We can't lose that North Star. When we do, we are lost. So I think that despite all of the pressures and the challenges that we have in healthcare, we have to bring that first and foremost to the table of these discussions, and we have to stay true to that. Because that's why we got into medicine in the first place, right? To help patients. So I carry my, Mayo Clinic value, the needs of the patient come first with me wherever I go, because that's really what we should be representing and advocating for. And if we just had everybody buying into that and not giving lip service to it, then we would be so much further ahead. And we can recognize that we have to solve financial challenges within that value structure, right? Like, I get it, no margin, no mission, Sister Generose, Mayo Clinic. But the second part of her quote, which people sometimes forget, which is actually equally important, is no mission, no need for margin. So healthcare should not exist to make money. Healthcare should exist to serve the community and the patients. And therein lies our challenge when we see big companies making a lot of money, whether that's in medical surgical industry, right? Or whether that's the insurance company, right? The goal shouldn't be to make money. The goal should be, yes, we have to make a margin, we have to make a profit so we can keep our doors open, but we make the profit so that we can serve patients, and that's where we have lost our way as a collective.
Yeah, I totally agree on that thought, and I think it's a great thought to end on. We're approaching $5 trillion if we haven't got there already. You can't tell me that it's not possible to deliver great care, take care of patients, and do just fine financially and make a margin. Doesn't mean you're trying to profiteer. Doesn't mean your goal is to make as much margin as you possibly can, although some might argue that. At the end of the day, take great care of patients, and there's enough opportunity in the system to make money and do well without harming the system and without extracting value but adding value. So I think that's
like you need to make a margin, right? And people need to get paid, and surgeons should be well paid. Primary care doctors should be well. Like that's really not the issue. So that's where, again, we go back to that North Star. Let's put the needs of the patient first, and I think that it will help guide the decisions that we need to make, because they're challenging decisions. I'm not, going to sugarcoat it and just make it simple, but that's what we need to do, because at some point, every single one of us becomes a patient.
For sure. Yeah, we all have a stake. Mary O'Connor, very honored to have you on our podcast. Again, we could have gone on forever. You can certainly find Mary on LinkedIn. I don't know, Mary, if you want to share any other areas or best ways to reach out to you. Mary's co-founder and CMO of Vori Health, and she's spent a long time within the musculoskeletal field and has been very innovative on driving these new models of care, holistic care. So again, thank you. And if you have any parting words or where people can reach out to you, I'll give you the last word.
LinkedIn is good. You can find me on LinkedIn. And thank you, Ben. And I very much enjoy your blog. I read it every time it comes out. So the Surgeon's Record, give you a little positive plug for that. And here's to us making healthcare better.
Agreed.